Good afternoon, everyone. Welcome to our next webinar in the EPN Emergency Preparedness Network webinar series. Today, we're talking about post-COVID clinical considerations in the home. And I'm really excited that Linda Justice Theodosio is our speaker. She's a division rehab manager at Viata and just an amazing human being. Let's move ahead. I wanted to take today and thank Dawn Seek. I'm not sure if she's on, but Dawn is the executive director of Minka. If you've been attending our webinars, you've heard me list her as someone you can reach out to if you have questions about EPN or about Minka. But I just wanted to take this moment and do a personal shout out and thank you for her leadership and her vision behind this webinar series, and just say that we're all really grateful that she is leading Minka and EPN. Speaking of EPN, the Maryland Emergency Preparedness Network is brought to you by the Office of Preparedness and Response at the Maryland Department of Health. So the Maryland Department of Health is supporting Minka and CNA Simulations VR, my company, to put forward this webinar series on issues that are important for the home care industry in Maryland during the COVID-19 pandemic. If you have any questions about EPN, if you'd like to get on our mailing list, if you'd like to join Minka, the Maryland National Capital Home Care Association, it's Maryland and DC's premier professional association or industry association for home care. That would be private duty home care, home health care, and DME. If you have questions about CNA simulations for education, you can always reach out to me, and let's keep it going. We have more webinars. You think the year's over, they're wrapping it up, but no, we're going strong. We just added 2 more. So next week on December 15th, Dr. Abrams will be returning to talk to us about caring for older adults with COVID in the home. So think about this webinar and the next webinar as a pair, where you'll really get to do a deep dive into the issues that are relevant for caring for older adults, both with COVID and post-COVID. And that will help you face this increasingly difficult winter with rising COVID rates and the twin pandemics of flu and COVID at the same time. On December 17th, we're having another CNA webinar, Caring for the Caregiver. We're going to hear directly from Ama Adepa Grin, who's a CNA who's been working in home care for years and who's worked in home care through the pandemic. She'll share her perspectives on how caregivers can focus on self-care. On December 21st at 4 p.m., I'm going to talk about aerosols. You've probably heard about aerosols on the news. Well, what do home care clinicians need to know about aerosols? Because home care agencies have teams that are spending hours and hours and hours in the home with older adults who may or may not have COVID. So we'll talk about that on the 21st. And on the 22nd, we're having another CNA-focused webinar. There's actually a talk show called Let's Talk CNAs, run by Angel Jackson and Wendell Anderson, and they're going to have one of their talk show sessions as our webinar on December 22nd. It's actually going to be in the evening at 7 p.m. And they're going to talk about how CNAs can protect their clients from COVID-19 when they're not at work. And so we invite clinicians, agency administrators, and caregiving professionals all to come and join us as we close out the webinar series with this final talk. But today we are excited about Dr. Linda Theodosio. She's a physical therapist who specializes in rehab for older adults for 3 decades. She's just a home health care leader. I met her through her membership on the board of the Maryland National Capital Home Care Association. She serves on multiple boards. She's developed multiple educational programs for the treatment of older adults. She's a physical therapist with expertise in home health care, a clinical leader, and we are so excited that she's going to talk to us today about post-COVID clinical considerations in the home. Take it away, Linda.
Thank you so much, Dr. Brown, and welcome everyone. This is really exciting. We have a lot of people on here today. I'm going to do my best. I'm going to share my screen here in one moment with my presentation. And we will get the PowerPoint started. Can everyone see the screen now that says post-COVID clinical considerations in the home?
Yes, we
All right.
can. And Linda, I'll just invite you to, or maybe I'll just jump in and suggest that those of you who have questions, please share your questions throughout Linda's presentation in the Q&A section at the bottom of your screen. So again, don't hold your questions till the end, just throw them in the Q&A section and we'll get to them when Linda is finished. Thank you.
Awesome. Thank you so much. Yeah, we have a lot of information to share. I want to thank Minka and also, of course, the Maryland Department of Health, Maryland Emergency Preparedness Network for making this possible. And also my boss, my company, Beata, for helping me make this possible as well, or allowing me to do this today. And also all of you for attending. I think it's really exciting that we're all in this together. We want to learn and provide the best care we can to our patients in the home, right? So the information disclosures today, the information is as current as it could possibly be. I was even checking sites yesterday. So you've got the most up-to-date I can provide you. Please stay abreast of all the information that's coming out. As you know, it's been changing constantly. It's kind of like being on a roller coaster, really. And last disclosure, there are no conflicts of interest or potential to benefit financially from the content of this presentation. So our objectives, they're listed here. Basically, I just want to say through evidence, the objective is to provide you with tangible takeaways, right? So that you can currently have the most evidence-based information you can have about this ever-changing virus and disease that's following it, and hopefully be able to make more informed decisions with your patients when you're in the home with them, when it's critical, and hopefully that you'll feel better about taking care of these folks after we're done talking today. So what a journey it's been, right? I think when we all started this, the fear was so great. We were all wondering, are we essential? Is home health really necessary right now? Patients were canceling us left and right. Clinicians were saying, I'm out. They were tapping out, not gonna see these patients, not gonna work right now. I'm scared. There was a recent, about 2 weeks ago, an article came out, which is really impressive. It was done by some researchers at the New York's largest home health agency. And they looked at over 1,400 clients who had been discharged from hospitals and came to home health with having had COVID. So over 1,400 cases since, I think, April through June. So they're huge, right? And remember, New York was one of the epicenters, so they had a lot of patients with COVID. And what they found is what you see here. So 42%, almost half of them had daily pain. 84% had dyspnea with any type of exertion. 50% had anxiety. We're going to talk about that a little bit. 85% had severe functional limitations. But what they found was after 32 days on average of home health services, 90-some% of I think 97% of them were discharged successfully to home without services anymore after home health. 88% of them were discharged with no adverse health events and no rehospitalizations once home health was in there. So that's pretty impressive. So you should be very proud to think that you're part of such successful outcomes for these folks and really understand the value that we provide. We are essential. This has been quite the journey these last 9 months, but we really are essential. So let's move on and talk a little bit about the pathology. You've heard a lot about this, but it is a virus, right? And it causes a restrictive lung disease. So I keep hearing on the news, the COVID disease, and I keep thinking, disease, it's a virus, right? But what they're finding is these long-term effects of this virus. So it enters the cells via the ACE2 receptors, hence why there's multi-organ involvement, but it seems to really be targeting the lungs. And what we're finding is there is thickened alveolar surface membrane, and it is a diffusion issue for these folks. So it is not like COPD. they can get the air in and out just fine. They just can't diffuse it into the tissues, all right? So it's an alveolar issue. They found this through a lot of post-mortem, studies. So the patients that we're seeing, because of this, they need more oxygen. They need a higher pressure of oxygen to get it into the tissues. They're desatting very quickly with minimal activity. Some are desatting with no activity. All right, we're going to talk a lot about that. So the clinical presentation, as we all know, can be asymptomatic to severe, resulting in that advanced pathology and multi-organ failure. So we're going to kind of take a deeper dive into each one of those. Now, keep in mind, we're in flu season too, right? So you've also got the influenza co-circulating out there with COVID. We've also been seeing a lot of bacterial and/or fungal infections with these folks, as well as community-acquired bacterial pneumonia. Here's an interesting study. They looked at 7 hospital emergency departments and 817 people over the age of 65 who presented to the emergency room and were diagnosed with COVID. And what they found was astounding, that 28% of them presented with delirium as well. 37% of that group, delirium was their only symptom. So think about, when we see patients in the home, and we go in one day, they've been fine. And then all of a sudden you go in one day and they're showing symptoms of delirium. And we're thinking, what's our first thought? Possible UTI, right? Well, now we also need to think, possible COVID. So keep this in mind as you're seeing folks in the home, who haven't even been diagnosed with COVID yet. Delirium is a huge factor now they're seeing. So 80% of the patients with COVID have an asymptomatic to a moderate symptom level, all right? These folks have shorter contagious periods, and these are the ones who usually quarantine and self-treat at home, okay? This is 80% of the whole population. Those numbers you see growing every day, 80% of them fall into this category, all right? 10 to 15% are going to be the severe symptom category. All right. These folks, sometimes we're going to be seeing at home, but they're the ones that often transition to crisis. And I don't know if any of you have seen these. We've seen them at Beata, where after day 5 to 10, they crash. And it's very, very important that you get them to the hospital immediately. You have hours before they're going to end up on a vent. Okay, potentially. All right. Hypertension seems to be the most common risk factor with this group. And when you start to see them, what I call tank, their respiratory rates are above 30, and their SATs usually start out in the 90s and then they crash. They become hypoxic very quickly. Okay. 5% of those folks diagnosed with COVID are the clients that end up in the ICU. And unfortunately, some of that 5% end up, not making it. So these are the critical illness, longest contagion period. They go into respiratory failure, shock, multi-organ failure, neurological symptoms. They can develop the cardiomyopathy, pericarditis, arrhythmias, all these things. These are the ones in the ICU, vented and sometimes pegged, okay? We're going to talk a little bit more about the pathology related to this, because we are seeing people in the home now that were in the ICU and have made it and have come home, and now we're getting them in home health, and we need to know how to handle them, okay? So hopefully you're going to get that from today. Okay, so these folks with the advanced pathology, they have extensive alveolar damage. Another thing that's been happening with these advanced COVID patients is this systemic inflammation and a hypercoagulation happening. So they're ending up with thrombosis of the lungs in the macro and the microvasculature, as well as distally and in large vessels of the organs as well. So these folks are ending up with strokes. They're ending up with skin manifestations and distal, thrombosis in their fingers and toes. And we'll look at some of that in a minute. So a lot going on with these folks, and we still don't have a full understanding of all of the pathology, but a lot of it has to do with this systemic inflammation and possibly due to the pro-inflammatory cytokines. I know you've heard about this stuff that ends up in the bloodstream, and then they end up in this cytokine storm, which just creates major havoc, multi-system organ failure. All right. So I think we all have heard who's at risk for this severe response to COVID. And it really is. Remember earlier I said, hypertension was the #1 comorbidity for people with the severe responses. Diabetes is another one, especially in the younger folks. But anyone with underlying risk factors, as well as people with just the normal aging. So age alone puts them at a higher risk, as we all know, right? Their reduced immune response. And let's not forget, these folks, older adults in general with no respiratory disease, already have a harder time breathing just because of the reduced mobility of the rib cage and the weakness of their, breathing, the muscles that help them breathe, okay? Overall, just through normal aging, okay? Keep that in mind when we talk about whether or not these folks should be wearing a mask when we're in the home, okay? And then let's not forget about congregate living. So all those folks that live in the senior living environments, they are much higher risk, okay? You put several people in one building together that end up with COVID, and now you have a huge viral load in that building. So we need to keep that in mind. There is an excellent, and I wanted to highlight it here, an excellent presentation in the American Physical Therapy Association PACER series. They put together several webinars that are free to everyone. You do not have to be a physical therapist. You do not have to be an APTA member. It's available to the general public at apta.org. And it's under their PACER series, and it's all presentations about COVID. And this one in particular, I loved, geriatric considerations for COVID-19 by Suzanne Greenwalt. So I've got that in here, and you can reference that if you'd like to watch it. I thought it was excellent. So some warning signs. Again, we know some of this stuff already, but it's a review. The potential for some patients to rapidly deteriorate. Remember that day 5 to 10 after onset of illness. So we need to be assessing them very, very closely and have some quick critical thinking and quick response if they start to deteriorate. Keep in mind those days, 5 to 10. The median time to acute respiratory distress syndrome, those ranges from 8 to 12. So there's another little window of time we need to really keep in mind when we're working with these folks that are quarantining and self-treating at home. They may flip to crashing very quickly around those time frames. And silent hypoxia. This is something they're seeing a lot with COVID, and these folks look good, feel good. They really don't have a lot of dyspnea. They don't perceive themselves as being in danger at all. So what does that tell you? We need to be monitoring them closely with our pulse oxes. And these people are actually desatting into the 50s. And if that happens, that's the quick response you need to be making. You need to be calling 911 right away, okay? Because they could end up in on event within hours, even though they feel good and look good. Some other severe abnormal responses to activity we're going to talk more about is that drop in systolic blood pressure and heart rate. They're developing arrhythmias, and they're having sustained desaturation. So we're going to talk more about that. And remember, delirium might be their only symptom. So we all know we have to protect ourselves, right? Be smart about it. Use the PPE that your company is providing and recommending. Follow the CDC guidance. Use those universal precautions. Teach those precautions to your patients. If anything, I'm thinking that flu And the spread of COVID hopefully will be reduced in the future just because the general public now knows how to wash their hands and how to sneeze and cough properly, right? But what about masking our patients? So I've had that question a lot at our company, as well as Minka has gotten this question a lot. Should we be asking our patients to put a mask on when we're in their home, or should we be mandating it? Well, let me just say that the CDC recommends everybody wears a mask, right? But they're not considering that our patients are already compromised. So these are some things that I'm not telling you one way or another which way we should go with this, but this is some stuff you need to think about when you're considering asking your patient to put a mask on. Remember the normal aging process, okay? They're already working harder to breathe normally, even without a respiratory problem. But you want to think, does my patient have other comorbidities that a mask would be contraindicated? So I wouldn't put a mask on somebody with COPD or interstitial lung disease, okay? Is my patient dyspneic at rest? Is my patient desatting during activity? Are they able to successfully breathe wearing a mask at rest? Can they tolerate it? Do they get anxious? Some of us get anxious putting a mask on. So you need to look at that with your patient as well. And are they able to tolerate a mask and perform the interventions during my treatment session without becoming distressed or hypoxic? And then there's the big question. You know, we need a doctor's order to put an ice pack on somebody. Do we need a doctor's order to ask the patient to put a mask on? Okay, and I'm just going to leave you with those thoughts. So now what we're really here for, right? We want to talk about, so post-acute COVID, what do I need to do in the home? All right. These patients are facing a lot of multi-system involvement after their acute stage of the virus. So one second. Here's some things they're looking at. They actually are seeing aerobic fiber muscle loss, so muscle wasting, diminished lower extremity function, very similar to post-intensive care syndrome and interstitial lung disease and post-sepsis. It's very similar to those presentations as well. They've got diffusion impairments in the lungs. They've got endurance and aerobic capacity impairments, rapid heart rate response to minimal activity, unless of course they're on beta blockers. They're dyspneic and decrease in oxygen saturation. And they may have vascular compromise, as we talked about a little bit before, and we're going to show you some of those examples in just a moment. All right. So I'm going to try to give you a little bit in each of these maybe system impairments as we go along here. So the respiratory presentation. These folks may have fluid in their lungs. They've got poor diffusion. You're going to hear me saying that the entire hour. It's a diffusion issue. Listening to their lungs, they could be clear in the large bronchioles, but they may have crackles or diminished lung sounds deeper into the lungs. So keep that in mind. They may have increased respirations to accommodate for their decrease in saturation, or they may be hypoxic. And we need to be making sure we are monitoring those respirations and their pulse ox throughout their treatment session. And the big question is, do I give my patient a pulse ox, or should they go buy one on Amazon? And the answer is, yeah, they should. If they've had COVID, they need a pulse ox, however you manage to get them one, okay? So let's look a little bit about the cardiac presentation now also. Trying to get my little notes here caught up. All right, so these folks are experiencing a high abnormal rate of rise in their heart rate, unless of course they're on beta blockers, all right? They're having a significant activity intolerance, maximum capacity with less stroke volume. And I just have here, remember, if they do have an active fever or low blood volume and they're dehydrated, they're gonna also affect their heart rate, okay? Not just the COVID. But if their heart rate actually decreases with activity, keep in mind, they may be throwing arrhythmias, all right? So what does that tell us? I don't know if any of you check their pulse through the pulse ox or through an automatic blood pressure cuff, but please do not. You've got to palpate or auscultate for their pulse or heart rate, please. I just can't even emphasize that enough. It's got to be manual, okay? It's very critical for these folks. We need to know. All right. The other abnormal presentation is through blood pressure. So they're going to either have an unusually high rise in their blood pressure with minimal activity, or they're going to have a drop in their blood pressure. And we're going to talk about that in a moment. These folks are also experiencing orthostatic hypotension. So please, please, please check this with your patients. Don't just go by the symptoms or their complaints of lightheadedness. Please check orthostatic. If they have it, they're going to drop within 5 minutes of standing or sitting, and their heart rate's going to rise. All right. So to compensate for it. So if their heart rate doesn't rise, that's a dangerous situation, right? And now let's talk about that exertional hypotension. This is the drop in systolic blood pressure during activity. So I'm hoping that all of you, when you do get your patients up to move, whether you're a nurse doing a tug at start of care or just walking them back to the bedroom so you can check their wound or whatever it is, and all you therapists out there, please take a peak activity blood pressure reading. That is where you're going to determine if they have exertional hypotension. They're not always going to feel lightheaded, but they will have a drop in systolic blood pressure of more than 10 millimeters of mercury, and they will usually get a little dyspneic as well. But these folks already are dyspneic, so you got to be checking it. All right. So out of all of this, the key takeaway again is monitor, monitor, monitor vitals. All right. Blood pressure, pulse, and respirations, as well as their pulse oximetry. Okay. During rest, during peak activity, during recovery, and resting before you leave their home. So their musculoskeletal presentation, again, this is the aerobic fiber muscle loss, right? And diminished lower extremity function. And another, I put the swallowing deficits here as well, because it could be muscular. It could be that weakness, that stretch because they were vented, who knows? Or it could be neurological, and we're going to flip to a neuro slide in a moment. But these folks have muscle weakness, functional strength deficits, balance deficits, pain. Remember, we talked about that in that study at the beginning. Their exercise capacity is poor, their gait speed is down, their ADLs and IADLs are significantly impaired. Their postural reflexes, please don't forget about that. The reflexes are diminished. That should have probably been on the neuro slide. And then we're also seeing dysphagia and silent aspiration, especially on those folks that were vented in the ICU. So don't forget to get your speech involved. The neuro presentation, we're seeing a lot of cognitive and mental health deficits, mostly in the most severe cases, the ones that were in the ICU. They're having attention and memory deficits, executive function impairment, visual spatial, mental processing speed, a lot of anxiety, post-traumatic stress disorder, and depression. So don't forget about that, and make sure we're assessing for those things and being sympathetic to that as well, and helping them to get the necessary specialists involved if needed. Speech deficits also, we're seeing aphasias, dysarthria, and vocal problems. So again, speech is essential as well. So post-intensive care syndrome, these are the symptoms of PICS. And I'm hoping you're seeing a similarity from what I just showed in the previous slide. Okay, the cognitive and mental impairments, as well as the musculoskeletal prior, right? Same thing. And the pulmonary function is declined, and they have pain. All the same things we're seeing post-COVID, we're seeing also are symptoms of this PICS, which is the post-intensive care syndrome that exists for people that have been in the ICU anyway. So COVID is mirroring that. This is also similar to post-sepsis. So keep this in mind with your folks. It's similar stuff. And we'll talk a little bit about recovery with these problems as well and how long that takes. The other thing, because we talked about the hypercoagulopathy that these folks are seeing in the severe cases, they're having circulatory and skin presentations, all right? And these are why. We talked about that a little bit already. The main thing I want to show you are these purple mottling skin and the purple toe lesions and the multitude of rashes. They can be raised, they can be flat, all kinds of things. And they're also seeing necrosis. So please, your takeaway here is you have to assess the skin and try to identify it appropriately. We're going to look at this now, and I should have given you a warning for anybody that's queasy, but here are some of the rashes. All right, this one's raised, these are not. Here's that purple mottling. But I want to talk about this right buttock. All right, on day 1 in the hospital, this patient presented with this lesion. Okay, and on day 3, it spread from the right buttock all the way through the coccyx, sacrum. It got larger, obviously, and now they have this necrotic space here. And the reason I said identify it appropriately is just be careful you're not calling this a pressure wound, all right? These manifestations they're seeing are not necessarily over pressure points. So this is a skin manifestation from COVID. This is not a pressure injury, all right? And here are what they're calling COVID toes. These are a definite manifestation they're seeing, and they're saying that this is due to that coagulopathy problem they're seeing in toes and fingers. All right, just something more to be aware of. Not that we're necessarily going to do a whole lot about it, but this is what the manifestations we're seeing with that severe pathology. So some treatment considerations based on all of that information. What do you need to think about as you're treating these folks? All right, hopefully you're getting it now. Monitor, 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 pulse ox, vitals throughout the session, okay? All right, mobility is medicine, one of my favorite lines, okay? We know that getting people moving improves a lot of things, right? Blood sugars, cardiovascular function, endothelial, right? Decreases chronic inflammation, regulates hormone levels, all of these things we know, right? So we've got to get them moving. So therapists, we are essential in the early phase of the rehab of these folks, okay? Don't forget about metabolic equivalents. And I just put this up here because the main thing I want to say about this is look at household walking level. This is the amount of oxygen utilized to complete a task, right? The metabolic equivalent. So this is for normal adults. Household walking is 2 METs, but keep in mind that our folks that are post-acute COVID, household walking to them might be equivalent to stair climbing, the MET level for stair climbing, or maybe even biking or running, all right? That's how they feel. They might be, their MET level for just household walking could be a 7 or an 8, all right? So just keep that in mind as you're working with these folks. Activity tolerance scales such as the Borg rate of perceived exertion. There are several dyspnea scales out there. I just put these up here. I know they're a little blurry. You probably can't see them the greatest, but they're not validated yet for people with COVID, and they're definitely not going to help you for those people with silent hypoxia. But I still encourage, and so does the core measures group that developed some of the evidence-based testing for these folks. They still encourage that we use them because it will help to teach these folks how hard to push and when to stop and rest, and based on how they're feeling. So you want to keep them somewhere between that moderate to somewhat hard level of activity on the RPE scale, and the same with how difficult they're breathing, all right? Teach them how to pace themselves using these scales as best you can. That's what this slide is talking about, but just keep in mind those with silent hypoxia, it's not really going to work because they're not perceiving that they're having any problem, but they do tank very quickly, all right? So I'm going to reference the APTA again, the American Physical Therapy Association. They got together a large group of experts in our field, experts in cardiopulmonary and geriatrics and home health and all the different sections got together and through evidence came up with a core set of outcome measures to help us all kind of, if we can use some of these outcome measures and share them across the continuum of care, we might be able to get some good information about how these people are doing post-acute, all right? And how the progression stands, and then maybe get some good research out of this down the road. I don't know, but it really helps to describe the trajectory of that recovery, right? So encourage you to consider using some of their guidance if possible. And here it is. So they're really encouraging that we start out looking at cognition for safety, making sure that we're assessing this patient's cognition and not, not leaving it by the wayside. Exercise tolerance using the 6-minute or the 2-minute walk test, the 2-minute step test or gait speed. And then lower extremity function, their recommendation is the SPPB, or if the patient is non-ambulatory, using the FIST, the function in sitting test. And then also any of the sit to stand tests if the patient is able. All right. The encouragement too, let me go back one. The encouragement here also is that even if the patient scores a 0 on the sit to stand test, still score that because that gives you that good baseline. And so you can only go up from there, hopefully. All right. So don't be afraid to score people those zeros and use that test. All right. So it's important that we really figure out how to prescribe the exercise and the return to function for these folks. Okay. And we're going to base it on those evidence-based tests. We need to make sure we're prescribing the right level of activity for them. So you're doing these tests, not just to do the tests because your company is making you do them, but really to help you guide you in determining your plan of care, right? We need to be teaching these folks to pace their activity, and we need to pace them much more slowly than normal patients that may have been in the hospital with pneumonia. Okay, these folks are not going to recover as quickly. We need to be doing respiratory muscle retraining. And whether you're using an incentive spirometer exercises or just the pursed lip breathing or diaphragmatic breathing, or you actually have the breather available to you for that muscle strengthening. Don't know how many people are using the breather. It actually strengthens inspiratory and expiratory muscles. So it's a really nice little tool. You can get it on Amazon. Strength, we need to be doing frequent small bouts of functional activity strengthening, including the repeated sit to stand as an exercise and a good walking program for these folks, even if it's 10 to 20 feet getting up every hour or whatever they can tolerate. Try to encourage these folks, figure out what it is they enjoy doing and build that into their home program. All right. They'll be much more compliant because they don't necessarily feel good. They're not going to be motivated to do these exercises that we want to give them. And if you make it fun, they'll be a lot more motivated. Okay. Holiday time coming, get on some holiday music and maybe they'll get up and move more, right? Aerobic capacity training, we need to be doing this in short, frequent bouts as well. So you need to be considering the duration, the intensity, and the response of each individual patient based on their evidence-based test results, right? If you did that 2-minute step test or that 2-minute walk test, use that to guide you in teaching them their aerobic capacity training again. And using the Borg or the dyspnea scales to help them also know when you're not there, when to sit and rest. All right. Your goal ultimately, but slowly and over weeks or months for these folks is to progress their home exercise program up to 20 to 30 minutes through interval training and then increase the intensity slowly. All right. Some basic physical and occupational therapy guidance there. So treatment considerations, post-COVID, it looks just like post-intensive care syndrome treatment, right? So we've got to face the cognitive strategies, We got to look at flexibility training, strengthening, task-specific functional training, slowly and steadily. Aerobic capacity training, same thing. Balance, circuit, and high-intensity interval training is going to happen later when they are medically stable and can handle it. How are we going to do all this? We're going to do it through monitoring their blood pressure and heart rate response, and don't forget their pulse ox responses, okay, their saturations. Let's talk a little bit though about the normal response to exercise. So normal blood pressure, you really shouldn't get much of a change, maybe a slight rise in their systolic with activity. Diastolic should stay about the same, all right? It's gonna rise a little bit more with upper extremity exercises, not more so than lower extremity, and a higher rise with static exercises rather than dynamic. So if we're concerned, we need to be doing much more lower extremity and dynamic exercise for these folks, but monitor them closely. All right. The abnormal responses, we talked about it. It would be a rapid increase in systolic or a steady mild rise in diastolic. And then extremely abnormal response is that drop in systolic. So do you stop moving these patients? Do you stop exercising them? Absolutely not. You pace them more slowly and you reduce the intensity of the activity. Because what might seem very mild to us could be, you know, like they're running a marathon. All right. Don't forget about orthostatic hypotension. All right. You need to work on being upright more and increasing their fluid volume. If they've got exertional hypotension, you need to have them rest until they recover so their blood pressure comes back up. Contact the MD, let them know it's happening, but do you stop? Nope. You continue to work with them with more episodes of recovery. And once the blood pressure comes back up, you can continue a little bit more during that session. But understand that their heart is not accommodating to the activity the way it should. So we need to go more slowly and lighter intensity in our activity. Okay. All right. Normal oxygen saturation response, it should stay about the same with basic activities. Sometimes the pulse ox will increase as they're breathing more deeply with more activity, but it really shouldn't change a whole lot. Abnormal pulse ox response is going to be greater than 4% point drop, or it goes below 90%. Okay, so what are you going to do with those folks? You're going to let them rest. You're going to do the deep breathing and hopefully get a better perfusion for them or diffusion for them. Give them time to recover in between each activity. Progress them slowly. Teach the breathing techniques that we talked about. PTs can titrate oxygen during activity if you get the order from the doctor. So that is a really good thing to think about with your patients who are on oxygen at home, titrating it up during the activity. But again, you need to get the orders from the doctor and you need to know how to do that safely. And again, if you do see a drop in pulse ox, you should see a rise in the heart rate and respirations. All right. Home oxygen considerations. I know we're getting down. This is so much information. So if your patient has severe dyspnea with activity, there's some things you can do. Of course, we've got our dyspnea recovery positions. Think about the titrating of the oxygen like I just talked about. And I'm going to move on to silent hypoxia. They are walkie-talkie. They only seem mildly ill. They don't feel like anything's wrong, but we see that their oxygen saturation is in the 50s. We need to contact the doctor immediately, probably 911, and get them to the hospital because they can very quickly end up on a vent. We talked about that. All right, I'm going to move on. I know you've been hearing about proning in home health or proning in the hospital in the ICU. This gives you a little bit information about proning. It basically improves the gradient and the pressure in the back of the lungs. And it's a very effective way to help somebody who's hypoxic or severely dyspneic. Can we do that in the home? Absolutely. We need to consider though how you're going to position pillows. I know this picture doesn't really give you, you know, a home scenario, but it's basically that reverse Trendelenburg, head higher than feet. You want to monitor their O2 sats while you're in this position. If they can't get into this position right away, you want to get them right side lying first, and then, or left side lying, and see if you can get them into prone from there. This is something they're suggesting if your patient is severely dyspneic and the recovery position doesn't work for them, or they're severely hypoxic and you've called 911, this might be a good position to put them in while you're waiting for EMS to arrive. Okay. Keep in mind, symptoms of COVID-19 may last weeks to months. I hear a lot of people saying, oh, but they're still symptomatic. They're still coughing. Is it safe for me to be treating them? It is. They're going to have these symptoms for weeks to months. Just understand that. Their functional recovery back to prior level may be delayed, most likely will be delayed, okay? And if they are recovering from the severe or the advanced pathology from COVID, you can expect months to years of symptoms that are similar to the PICS to be present. Because again, they've had multi-system organ involvement, muscle wasting, and you know, it's gonna take them a long time to recover. So just keep that in mind. Thank you so much. I just want to leave you with one parting thought, and that is continue to double down on safety protocols. Thank you so much for the care that you've provided these patients all these months. It's been quite the journey. And thank you for joining us today. I can be reached. I have my email here and my cell phone number here. If anyone wants to reach out to me, feel free. I believe, Dr. Brown, this is recorded and it's going to be available on the website for people to view later as well. And what about the slides? Can we share that with them?
Absolutely, yes. That will also be available on the website.
Okay.
So, Linda, that was a phenomenal presentation. I'm amazed at how much information you shared in such a short period of time. And
it was hard.
And you shared it so well. It was amazing.
Thank you.
And you inspired some questions. So let's go ahead and get started. Laura Silverstein has a question. She's been hearing about joint pain and weakness post-COVID. Are there any official reports on this?
Thank you, Laura. If there are, I'm not aware of them. I know that pain has been a significant consideration and is present in a lot of these folks. Anything more specific than that, I haven't seen. Are you talking about the ones coming out of ICU that were like the severe pathology? I'm thinking that's probably what it is. And you know, let's keep in mind they haven't been moving, right? And how much did they get them moving while they were in the hospital? Who knows, right? I don't know if there's actual joint pathology that's happening. That may be information to come.
Okay, great. Let's see what Julie Mills would like to know: the long-term impact of smoking for someone who has mild to moderate symptoms.
That sounds like a great research opportunity for someone. I don't know. Honestly, I don't have an answer there, but that's a great question. And, you know, I'm really thinking we're going to start to see a lot of research coming out. The immediate research that's been done, other than the one that I showed you from the New York Visiting Nurses Service of New York, the rest of the research that I've seen so far has been, unfortunately, on post-mortem, where they've found, you know, the alveolar damage and some of the other things. So, or they've just been retrospective observational cohort type things. So I think there's a lot more to come as time passes that we're going to learn about this disease. Yeah. Great question though, Julie. Thank you.
It is. And I agree. There hasn't been enough time to understand the long term.
No.
How do you measure peak activity blood pressure? Do you use an automatic blood pressure cuff and turn on while walking or exercising?
Great question. I'm not a fan of the automatic blood pressure cuffs. So, I mean, if that's the easiest way for you to do it and to get compliance, that's fine. I have the patient, when they feel they're working hard, then that's when I have them stop and I take their blood pressure. And as long as, and I do it manually, but as long as you do it within, a minute or two, you're going to be okay. All right. These folks are not going to recover that quickly. So, you'll be fine getting the peak at that point.
Fantastic. Thank you, Linda. So let's open up the Q&A for any new questions for Linda Theodosio on post-COVID clinical considerations in the home. Oh, we have an awesome job, Linda. And we have a thank you.
All right. Thank you.
A couple of thank yous, actually.
Wonderful.
Wow. Okay. Well, let's take a moment and just see if there are any more questions. I have a question, Linda.
Okay.
So in your own personal practice, what has surprised you the most? Like the one thing that surprised you the most that was, oh wait, maybe my question will be subordinate. We'll delay my question for the anonymous attendee who is asking if there's research backing the claim that people with I guess blood type O are somewhat protected.
Oh, again, you guys are smart. I have no idea.
I've heard some stuff about blood type. I'm not sure how valid it is, whether it's on the hypothesis end of the spectrum or on the proven side of the spectrum.
Yeah, I don't know either. I'm an O type and I got COVID, so I can't tell you.
Oh my goodness. Well, I can actually flip my question. So my question was, what did you find most surprising in your practice? And then also, what did you find most surprising as a patient about COVID personally?
Wow. So most surprising in the practice, that's a tough one. I'm going to say the vast involvement of the multi-system involvement that these folks are facing. And it doesn't seem to be just because they were sick and inactive, right? We know that, 1 day in bed takes 4 to 7 days to recover, right? For older adults, it's way beyond that. These folks have actual, wondering if the virus is actually attacking all of these systems, or are these other problems that they're having just secondary, and that's what we don't know, the whole pathology. So I think I found that most interesting and most surprising to me, because when it first started, we were all thinking it was just like a viral, upper respiratory involvement. And then as time went on, we're seeing all these other systems of involvement. And that's where it's really kind of frightening and challenging at the same time. For me, the biggest surprise was how long it took me I'm a relatively healthy, I don't have any other comorbidities, I'm fairly active, and how long it took me to feel better as a normal, healthy adult.
Mm-hmm. Well, I'm glad you did recover.
Oh, thanks.
And I'm glad you were able to write this presentation, both through the lens of your own experience, but also as a clinician.
Thank you.
We had, I guess, Dr. Kamaldeen Sani. I can't tell if you wanted to make a comment or if you had a comment, but we saw that you put comment in the Q&A. So let us know if you have a comment or a question, and anybody else, this will be our last call for comments and questions. We got more. That was a lot of great information. Thank you, Linda. Amazing presentation, Linda. Got to run. Thank you to both of you and for the great info.
Thank you. Thank you so much. It's so much information out there, and I was really stressed at whether or not I'd be able to fit it all into a 1-hour presentation, and I hope it wasn't too fast or too confusing. So No,
it was fabulous. And you honed in on the types of things that a clinician working in home care wants to know and needs to know. So we did have one more. Oh, thank you. Excellent presentation. It was fabulous. So we're just getting all the love, Linda, all the love. Like lots of people affirming what a phenomenal job you did. So with that, oh wait, is this another? Yep, another like that. Thank you. Excellent presentation. So Linda, thank you, thank you, thank you. I'm gonna take over the screen and thank our sponsors one more time. Let's see. Okay. All right. So thank you, Emergency Preparedness Network. Thank you, Minka. Thank you, my company. Thank you, thank you, thank you. For all of you who attended and participated with all of your phenomenal questions, we are thrilled by the attendance and the engagement. And again, keep us in mind for the upcoming webinars. We have 4 more. 2 of them are on the website. You can register today, and 2 of them will be on the website by the end of this week. Again, that website is mdemergencyprepnetwork.com, and just go to the events page. All right, thank you, everybody. Have a wonderful weekend. Bye-bye.